Good day, and thank you for joining. On behalf of the National Center for Primary Care, we welcome you to Part 1 of our Opioid Use Management webinar series. We also invite you to connect with us at PriCare Matters via social media and at www.primarycarematters.org. You can also access our website for all archived webinar recordings and presentations. Additionally, today's webinar recording will be available at www.primarycarematters.org, and the webinar presentation will be available at the end of today's webinar. The National Center for Primary Care is located at the Morehouse School of Medicine. The NCPC is a national resource for encouraging doctors to pursue primary care careers, for making primary care practice more effective, and for supporting primary care professionals serving in underserved areas. The core principles of the NCPC are access, effectiveness, and equity. Today's webinar is made possible through a partnership between the National Center for Primary Care, the Southeast Addiction Technology Transfer Center, and the Recovery Institute of Southwest Michigan. The objectives for today's webinar are to identify techniques being used to identify patients with opioid use disorder, to examine opioid prescribing guidelines and protocols in various states, to evaluate methods for treating patients who are addicted to opioids, and to explore methods of communicating with patients who are seeking opioids. I now present to you today's webinar entitled Detection, Treatment, and Trends in Opioid Use Disorder, presented by Dr. Merrill Norton and Dr. David Whiters. In compliance with ACCME guidelines, none of the presenters have financial or other relationships with the manufacturers of any commercial service discussed in today's activity. We will begin today's educational session with a recovery testimonial from Ms. Amanda Santos.
Hello everybody, I'm Amanda, recovering heroin addict.
Thank you, Amanda. Can you please share the events which led to your opioid addiction?
I guess it started in high school. I ended up getting a knee injury, and they gave me prescription Vicodin or Norcos at the time. Right after I had my oldest son, they gave it to me again because I had to get an epidural redone 3 times. So I had a taste for it, but I didn't actually start seeking prescription pain pills until I was actually in the military. I had another injury from jumping out of an airplane, and I just kept making stuff up. It was my back, it was my knee, you know, stuff like that, and nothing ever helped, so that's when they would try different avenues, but it was always an opiate.
And what was your daily struggle like when you were battling your opioid addiction?
Once I became addicted to heroin, because it progressed into heroin, once I became dependent on it, I would wake up, if I had money, it would go right to the drug dealer. If I didn't have money, I would beg, borrowing or stealing to get it, and it would last all day. So by the end of the night, I was exhausted, but I was finally high, and then it'd start all over again as soon as I woke up.
And what was one of the lowest points during your addiction?
I would say when I became pregnant for my 3rd child, because I found out I was 3 months pregnant. I tried to just stop using, and it worked for about 3 months, but then I had a relapse of heroin at 6 months pregnant. And I guess I can sit there and say that was the lowest point, but I didn't start feeling any low points until I wasn't using anymore, and it was completely mentally out of my system.
And how would you characterize your path to recovery?
I feel like I have a purpose, just spreading hope to other people who are in active addiction or trying to get out of it, becoming more involved in community things like this, like the opioid epidemic, just making myself vulnerable so other people can understand that recovery is for everybody.
And we have a webinar filled with health professionals and clinicians. Do you have any take-home messages that you would like to share with them before we start the webinar, or things that they should consider as we're transitioning through this educational series?
I guess just the point of the whole webinar is just pay attention to the seekers, because that's how my heroin addiction started. I just kept getting it and getting it and getting it through the doctors. And then once it finally stopped, I would just hit the street. So I don't know how to stop it, but that's something to pinpoint.
Thank you, Amanda. And I want all the attendees to know that Amanda will be available for question and answer. And now, Dr. Norton.
Hey, everybody. Glad you could join us this afternoon. I'm going to give you a very, very brief overview of the dilemma, which a lot of you are quite aware of, and so we'll move forward. This is called the pain of pleasure, heroin and other opioids, implications for healthcare practitioners. Probably in the last 6 months, I have trained over probably 4,000 physicians, specifically with medical boards and specialty areas, my latest group being oncology, and how they can detect any kind of opioid use disorder inside of their treatment populations, even though it's a high-risk populations because of the types of treatments they have to have. The reason I'm here and participating today is that we continue to have a death rate that continues to skyrocket. Most of you are familiar with statistics, and they change from year to year, but I will say this: in 2016, over 59,000 overdose deaths were reported. That number is greater than the deaths that occurred in the Vietnam War. We anticipate if the continued rate at this particular year in 2017 continues, we will have almost 70,000 overdose deaths. As we look at the reasons behind it, and again, I don't want to finger point at physicians, because it's not only a physician problem. It's a social problem. It's a national problem. But when it comes to addiction, and I've trained many physicians and hundreds of, and I'm at the University of Georgia, and we involve ourselves with pharmacy and medicine and nursing and other things. One of the issues with misdiagnosis is the amount of time it takes to detect a addiction issue. It takes time, it takes experience. Part of that time, and also it's not on the side of the practitioner as it is on the side of the patient. The patient will not give you all the information. My wife is a nurse practitioner, and what she does is she has about 5 to 10 minutes to talk with her patients and to go about identifying what the problem is that they came to see her for. And the issue may be is that they don't share with them any type of history of previous treatment, history of any kind of addiction, whatever. What I have discovered, which is a little better in most, and this is why we have in this webinar, is the lack of training in practitioners, where they're focused on so much of the target of what I need to do instead of looking at a bigger picture. And I will be honest with you, the detection of addiction can be a very simple thing, but also it's a very complicated thing. Part of it has to do with the patient's presentation, where patients will be dishonest or difficult, and will not be reliable sources of information to get the appropriate information that would help people understand they could be a possible substance use disorder present. There's also the multiple diagnosis that people come in with. This is because I had this pain, and this is what Amanda was talking about, and this is what my issue is, and so on and so forth. And then, of course, the issue within our own implicit bias. It's our own belief system, and what we find in the research is that with chronic disease states, especially in regular family practice settings, you've got diabetics, and you've got chronic smokers, and you've got chronic people who will not take care of themselves, and blood pressure, and they're obese, and so we create kind of a wall between us and the patient. And sometimes that leads us to kind of discount some of the things that may happen. These are primarily the few of the things that I noticed that most have, at least the practitioners I have trained, have reported to me as being part of the issue that could lead to a misdiagnosis. Addiction liability is very high. We're talking about opioids. We're talking about and there's multiple drugs of abuse in our culture. With marijuana, we've got, and I spend a lot of time, about 50% of the time, training practitioners to what they do inside of states that have legal cannabinoids being used. How do I prescribe that? What's the dose? What do I need to do? Et cetera, et cetera. your addiction liability is about 9% for those who are using any type of cannabinol. Ethanol, we estimate it's 15%. Cocaine, even though it's not as prevalent as it was, it's still on the rise, 17%. When we talk about heroin and opioids, about 23% is the addiction. That's the number of people who will actually develop a substance use disorder over the ones who we consider to be in an abuse situation with that particular drug. And tobacco, of course, continues to be a rate. It's interesting, though, because there's some questions that were sent to us prior to this webinar. We have 92 million people who are using opioids on a regular basis versus there's 79 million people who are using tobacco on a regular basis. For the first time in history, we have another drug that's actually surpassing tobacco as being the #1 drug of abuse. So as we look at this situation, why do they do that? Well, I don't have time to go into this. I spend semesters explaining this to practitioners. I spend days and weeks, and that's what keeps me busy. But you have multiple different networks that are impacted by the use of any psychoactive substance, but specifically opioids. The reward system, the anti-reward system. Your reward system is the pleasure center. The anti-reward system is the pain center. Your stress system, which triggers and regulates between both the reward system and the pain system. Your brain-derived neurotropic factor system, which is your mood regulator, has to do with that. The neurochemical neurotransmitters, dopamine, the acetylcholine, having to do with GABA, glutamate. Your receptors, we will talk a little bit about that in a minute. The drugs themselves, we got more potent opioids on the market than we ever have, even though we've just withdrawn a PANA, which is a sacrificial lamb, I call it, having to do with the networks, but they're very, very potent. Genetics are still a huge problem with the connection with a person. Just simply by asking a question, people want to know, what do I do to interview people? Do you have a family history of addiction? Yes or no? Do you have a family history of mental illness? Do you have a family history of suicide? Do you have a family history of trauma? Those 4 risk factors, very simple, but I find none of that on most intakes as we see people coming into new medical practices. Mental component, the obsession. Amanda talked briefly about that. The cravings, which have been added to the DSM-5. And, of course, the ongoing unbelievable process called relapse. And so we have multiple systems that are impacted over time. I call opioid addiction, it's greater than a mother's love. And a mother's love, as we've discovered, it is a dynorphin. And for you that do not know what dynorphins are, those are biochemicals that your mother gives you at birth. It gives her the greatest experience she's ever had living, or at least most women have it if they have normal brain chemistry. And it also gives that infant that overwhelming bonding memory of their mother, their connectiveness of that mother. And one of the things that we will explain in just a second, what we've discovered recently, is the reason that addicts cannot stop using is once that dopaminergic system is deactivated, due to multiple neurobiological reasons that we will not have time to go into, the reinforcing facts of the drug become more powerful than a mother's love for her children. That is why addicts will put their drug over everything else in their world. In 2016, the potencies of most street drugs, marijuana, heroin, have increased. We've now added fentanyl to the heroin mixture. The increased potency creates increased reinforcing effects of the dopamine, thus increasing the addiction liability in the brain itself. So what we see, y'all, is if we want to look at the very, very brief overview, people start out liking a particular drug. They can use it occasionally. Some people like alcohol, some like beer, some like wine, some like marijuana, some like opioids, some like heroin, some like OxyContin, some like codeine, some like, hydrocodone. But once in a great while, it stimulates that dopamine and we go, whoopee, it makes good. The thing that really gets people in trouble is when we move from increased use, and that's when we develop a pattern of use. We not only involve the dopaminergic system, but we involve the endorphin system. And the endorphin system, y'all, if you do not know what endorphins are besides those things that make you feel good after a good workout, is it creates the reinforcement components of a psychoactive substance. The endorphins are created, and the euphoria is created by dopamine. The endorphins is created by, and the reinforcement is created by the endorphin system. So you got dopamine and endorphins. I like it. If it makes me feel good this time, it's going to make me feel good again and again and again. And then you have the granddaddy, which is your dynorphins. Your dynorphins are responsible for your stress management. They're responsible for, and we've discovered it's recently in the neuropsychiatric field, they're responsible for the feel-good that we get in our intimate relationships. And as a result of that, y'all, when you have a highly stressed day, where do you want to go? You want to go home. And why do you want to go home after a highly stressed day? It's because that's where your dynorphins are. That's where those intimate human relationships are that help us overcome and manage our stress mechanism. So what we have, y'all, is it's as we will go through this, the dynorphins, the endorphins, and dopamine are all impacted by opioids. Now what this is, and this is a very simple brain in a very simple way because the time I have is very limited, but you start activating circuit 1, use, dopamine, I get relief from my pain, or I really like that chocolate cake, or I really like the way it makes me feel, because it activates what we call the pain pleasure circuitry in the accumbens in the brain. Now, if you use occasionally, you're going to stay up in circuit 1. But if you start to use on a regular basis, you go to circuit 2, and that is where you find the endorphins, and the endorphins simply tell you, this makes me feel good again and again. It creates the repeat business, for lack of a better word, and it creates the want to. I really want to use this particular drug. And this is where the brain begins to separate out where an individual's particular drug of choice may be. But the thing about it is, y'all, as you begin to use repeatedly, and as we will say, and Amanda could tell you, and others will tell you, of many addicts that I have seen, is that they will quickly increase a normal dose. I'm a pharmacist, and as being a pharmacist, being involved with normal dosing, instead of having 20 milligrams of hydrocodone daily on board, they will be taking 400 milligrams of hydrocodone on board, and then mixing it with alcohol and other things. And so the problem that you run into is you deplete your dopamine. So circuit 1 shuts down. The endorphin system tries to come up and replace what the dopamine does, and so you begin to have gaps in what happens because your thinking's not quite right. You can't remember this. You begin to forget things. Your driving is not as good because the endorphins don't do the same thing as dopamine does, but it's trying to fix the system. But what people think in their brain is, I'll just take more drug, and when they take more drug, guess what? Circuit 2 shuts down. And then you've got the granddaddy, the dynorphins come in, and the dynorphins try to do the same thing as the endorphins and dopamine, and it's the pathologic desire demand circuit. And so guess what? You continue to increase that dose, and eventually what happens, y'all, as we're beginning to look at this closer and closer, and what happens especially with opioids, the opioids simply replace the dynorphin system as being the predominant stress reduction mechanism in the brain. And that creates the need and the craving. So the thing about it is, as you begin to look at the pathological desire demand circuits, especially in the gray part of the brain stem, we begin to have this. And so what happens is that drug becomes the most important relationship in a person's life. And to make a long story short, they come in. How do we treat them? We stabilize them with opioids. Sometimes we have to send them to MAT to keep them out of withdrawal. We have to use naloxone to keep them alive in order to get them to MAT. And if we can get them to MAT, we should sometimes step them down into an abstinence-based program. And the thing about abstinence-based programs is the one way that they do it from behavioral medicine is they create relationships with people who are other addicts. And what happens to rebuild this circuit, you start at the circuit 3 first, increase the dynorphins. If you increase the dynorphins over time, it begins to rebuild the endorphin system, and once we rebuild the endorphin system, then you rebuild the dopaminergic system. And people say, well, how long does that take? It takes years to redo that. And so basically this is a simple brain that I have. You come in here with a normal brain, and you have a thinking brain and a prefrontal cortex, and that has to do with your judgment brain, and you have an instinctual brain that includes your pleasure centers, which includes the nucleus accumbens, and also the ventral tegmentum area. And basically a normal brain will say, I want a beer. And why do you want a beer? It goes to the nucleus accumbens and it says, it makes me feel good. And then from the nucleus accumbens, it goes to the ventral tegmentum area, which is your memory system, and it says, Miller Lite. I want a beer. It makes me feel good, Miller Lite, which is normal in the brain focus, normal. But in addiction, what happens, the neurobiology of reward, the science has recognized that the circuitry involves a rich bidirectional circuitry between the nucleus accumbens and the basal forebrain. This means the brain has several different pathways for the brain to experience different types of pleasure from various drugs. And people ask me about behavioral addictions, food, and gambling, all very similar. They have different types of pathways, but it's the same basic system. It is the reward circuitry where the reward is registered, and is the most fundamental rewards such as food, hydration, sex, and nurturing exerts a strong and life-sustaining influence. In addiction, what happens is the neurobiology of craving is what I call it. Anytime this brain feels stress, once it has become addicted, once it has a substance use disorder, the first thing that happens when it feels stress, Miller Lite. And the reason it does that is it has no backup. It has that dynorphin is not present, and that craving hits it, and once it has Miller Lite, then it will go over here to the nucleus accumbens, and it says, it makes me feel good. And that's what we call euphoric recall. And when we have that euphoric recall, unless we have placed mechanisms in the prefrontal cortex behaviorally, neurolinguistically, if it be recovery, AA, go to meetings, call your sponsor, do the next right thing, whatever it may be, then guess what happens? The brain will simply come up here and tell the individual, I want a beer, and the relapse dynamic can occur. Because, y'all, I have nothing but a very, very limited way to manage cravings. I do have a Campsilade, I have naltrexone, I have some other medications that we use, but they're very short term to manage this circuitry. The things that we have is to manage it in a more appropriate way is to create a a cognitive behavioral mechanism in the prefrontal cortex that gives them a new neural pathway that simply offsets the craving from the standpoint of behaviorally seeking that consumption of a particular drug. And so that's very simply as I can put it anyway, in a very abbreviated time that I have. And so the thinking brain has to be reconfigured, and that's why we have multiple treatments that tell people, don't drink, go to meetings, work the steps, etc., etc., etc. And that's very important. We do have pharmacological options, which I will tell you about. We have to keep people alive, so we have naloxone, which is an overdose prevention. The CDC has reported for most people who are now going into MAT, a lot of them who have overdosed multiple times and have been rescued. In my particular facility, we have probably 2/3 of our patients are opioid addicts, and over half of them have been rescued multiple times. But I can't treat somebody if they're not alive. That's the thing I tell people. I've got to make sure they live till tomorrow if I'm going to do anything with them. Once we have them, and we have people who have severe withdrawals from opioids, then we have the pharmacological approaches of MAPs, which include methadone, buprenorphine, and then we can use naltrexone and, of course, naloxone. And then from those types of treatments, people can be stepped down, if they choose to, into ASAM patient placement criteria, which has 7 levels of care, which we do not have time. And I think David will probably talk about that in a very brief way. Thank you for your time. Here are your references, and I hope that was helpful. Thank you very much.
Thank you, Dr. Norton. And now we will transition to Dr. Wieder.
Thank you so very much. Thanks for the invitation. Merrill, that was an awesome presentation. I'm just sitting here listening, and I've seen you or watched you present on this information for more than 15 years now, and it's always very, very exciting. So thank you so much. It's good to be able to share the podium with you today. And thank you to Amanda for that awesome testimony. Thank you for your service, and I'm glad that recovery is working for you. My name is David Jabula Whiters. Jabula is my surname, my middle name, excuse me. When I was a graduate student at Michigan, I completed a 4-month internship in Durban, South Africa, working at the AIDS Foundation of South Africa. I was blessed with the opportunity to help develop programs that made a connection between drug use and HIV in South Africa while a graduate student. It was during the time when they weren't making the connection between drug use and HIV. And my name is Zulu. I lived in a place called KwaZulu-Natal, land of the Zulus. I'm an adopted Zulu. That means peaceful, it means happy. So, and I've been blessed in that I've been back to Durban, South Africa several times. And each time I go back, I get a chance to see how much the recovery community has grown there. I was also blessed with the opportunity with helping to develop a 12-step recovery community in Durban. I'm a person in long-term recovery, and what that simply means is that it's been more than 33 years since I used any drugs. I'm a recovering heroin user. I achieved my recovery initially in a 12-step program that I'm still a faithful member of, but I've added to my recovery paradigm my faith. I'm also a Christian, so I utilize both programs to help sustain me and help grow me in my recovery. Sometimes people ask me which program is most important, and the answer to that question is very, very simple. Neither is more important than the other. They both have value in my life, and I utilize them both to sustain me in my recovery. Real quickly, I want to say this, that even though they're both our spiritual programs, sometimes they can conflict, not to a great degree, but in some ways. For example, in my 12-step program, we utilize language like higher power so that we're not any religious-specific, so that we don't use religious-specific program. And in my faith, we use a very specific term when we talk about God or when we talk about Jesus. And one of the things I've learned over the years, over the 33 years that I've been in recovery and over the 20 years that I've been involved in my church, is that when I'm in my 12-step recovery program, I utilize language that's specific to my 12-step program. And when I'm in my faith community, I utilize language that's specific to my faith community, and that works for me. It cuts down on the confusion. I don't have to worry about people in my 12-step program say, Dave, why do you go to that stupid faith program? Don't you know that Christianity is for folks who are trying to save their asses or trying to not go to hell, and 12-step programs are for those of us who've already been to hell. Or in my faith community, when they say sometimes, David, why do you keep going to those stupid 12-step programs? Don't you know that through Jesus, all things are possible, and now that you're a Christian, you don't have to be involved in it anymore. So that I don't have to hear that those conflicting conversations, I just avoid having conversations. In my 12-step program, well, that's not totally true. Because in my faith community, everybody knows I'm in the 12-step program. And let me tell you why that's important. Because there's always somebody in my faith community who has a son, a daughter, an uncle, an auntie, a brother, a mother, a father who's struggling with addiction. And they know that I'm in recovery because I tell the world that I'm in recovery. And they come up to me and they say, David, I need your help. Can you help me? And so I like being able to talk about both of my programs. But again, I know when to talk about them and I know when not to talk about them. I'm glad, well, I consider myself a subject matter expert on addiction and addiction recovery. And that's partly because I've been using since I was 13. I started using when I was 13. I started injecting heroin when I was 16. And I started my recovery when I was 26. I don't have a high school diploma. I dropped out of high school to be a drug user full time. I didn't figure you need a high school diploma to be a substance user. And I figured that I would probably overdose and die like many of my friends, or worse yet, end up spending the rest of my life in prison. I've been able to combine my lived experience with formal education. I have a GED. I have an associate's degree in mental health and social work. I have an undergraduate degree in general studies. I have a graduate degree from the University of Michigan in social work, and I have a PhD from the University of Georgia in social work. So I've been able to take my lived experiences, combine it with formal learning. To me, that is what now makes me a subject matter expert on all things addiction and all things addiction recovery. And Merrill pointed out, I want to talk about a couple of the social determinants that I think impacted my life and may have led me to become a substance user. I'm not absolutely certain about this, but I think that these realities played a part in me using drugs. I have 5 brothers and 5 sisters. I come from a fairly large family. Some people would say 11 is more than fairly large, but that's large. I have 5 brothers and 5 sisters. 4 of my 5 brothers are drug users. 3 of them are heroin users. The 3 that are heroin users are all older than me. I grew up watching them nod from the time that I can remember what nodding was. I can even remember when I was a kid, I said to myself, when I get big enough, I'm going to nod like that. Because they always seem to be in this peaceful state of mind. And that's what heroin seemed to do for them. It seemed to cause them to be at peace. And I couldn't wait till I got of age where I could access whatever it was that they were taking so that I could feel like that. And the other thing, too, is one of my other brothers, who's a younger brother, is cannabis dependent. And I'm happy to report that all 4 of my brothers are in recovery. I was the first one to get in recovery, and then they followed me. 2 of them are active in 12-step recovery. 1 sustains his recovery solely in a faith-based community. He's also Christian. And my younger brother, who was a cannabis dependent or a marijuana addict, even though he went through treatment and started out in 12-step recovery program, he now sustains his recovery just by not using. Also, one of my 5 sisters, who was my older sibling, was also alcohol dependent. She actually had 9 years sober in Alcoholics Anonymous when she died from ovarian cancer in 1986. I started my recovery because of her. She said to me one day, she said, "David, you need some help." Now, I didn't think that anybody knew that I had a problem. Later, I would find out that everybody knew I had a problem. I just thought nobody knew I had a problem. She took me to a treatment program. It was in Holly, Michigan. And maybe Amanda is familiar with the treatment program that was in Holly back in the years. And I didn't have any money or any insurance, and the only reason why they took me into that program was because they knew her. I remember they said to me, quite frankly, the only reason why we're taking you into this program is because your sister is a good member of Alcoholics Anonymous. The other thing I want to point out is that heroin was easily accessible in my community. I grew up in a community where heroin was sold on the corner in open-air markets. You could walk out your house, walk down to the corner, and cop. The high school that I went to, that I dropped out of high school from, I used to buy heroin across the street from my high school before I was going to my first class. And that's how accessible, easily accessible it was for me. And so I think that maybe those 2 things, and probably other things, contribute to me becoming a drug user. I want to segue to a historical perspective on this thing that we're referring to as the opioid epidemic. Later in my presentation, in my short presentation, you may hear me refer to this as a white people's epidemic. And let me tell you what I mean by this. The opioid epidemic ain't new. It's been around for years. As a matter of fact, during the turn of the 20th century, in the early 1900s, there was an opioid epidemic in this country, in the United States. And the users were primarily white Americans. They were addicted to things like codeine and what's the one that you get when you go to have surgery? It starts with an M. It's just escaping me. But the initial opioid epidemic that we're experiencing in this country, and you can read this in Slaying the Dragon, The History of Addiction and Recovery in America, written by Bill White, and you can also read this in other articles, a couple of which I have listed as references at the end of my presentation. And we treated it back then as a public health issue, and rightfully so, because that's what it is. However, the face of the opioid epidemic changed, and that's if you include heroin in this epidemic, because in the 50s and 60s, it became an epidemic that was primarily among black Americans. And it first landed in one of our nation's most prominent African-American communities at that time, which is Harlem, New York. And you can read the history of this epidemic, heroin epidemic in Harlem, in Claude Brown's book, Man, Child, and the Promised Land, which is one of the greatest books I've ever read. I read that book when I was a kid. It's about this young brother who grew up in Harlem during the time of the Harlem Renaissance, when Harlem was famous for black businesses, black art, black entertainment. It was the who's who of black people. Anybody famous who was black ended up in Harlem. That's how Malcolm X ended up in Harlem. Billie Holiday was in Harlem. Langston Hughes was in Harlem. It was just full of art, music, entertainment, businesses, and bam, out of nowhere, heroin was dropped down in this community, and Malcolm writes in his book, The Autobiography of Malcolm X, and so does Claude Brown in his book, Man, Child, and the Promised Land, that heroin hit Harlem like a plague. All these brothers and sisters who used to be great musicians like John Coltrane, Miles Davis, all succumbed to the heroin epidemic. And a community that was full of art and entertainment all of a sudden became a community where you could walk up and down streets and all brothers and sisters were sitting on the corner and nodding. So, now, you would think that since we had already had an experience with this in the early 1900s, that we would know how to address it. We would address it as a public health issue the same way we did when it was an epidemic among white people. Wrong. We treated it as a criminal justice system, a criminal justice issue. And as opposed to finding ways to treat brothers and sisters, guess what we did? We found ways to incarcerate. We criminalized their drug use. We turned them into criminals. We called them bad people. And we found ways to incarcerate. Well, here we are again in the 21st century with another opioid epidemic. An epidemic that I guess we're including heroin in this epidemic. I hear people say opioid epidemic and heroin epidemic, or heroin and opioid epidemic, as if heroin is somehow separate from the rest of the opioids that are being used and abused, or used and misused. In this country, according to the National Institute of Health, there are a little more than 2 million prescription opioid users. There are 467,000 heroin dependent users. Let me tell you, it's important that we understand this if we're going to know how to treat this epidemic, because in my more than 30 years of being in recovery, the one thing that I can tell you that I know for certain, that access to care, health disparity, for those who are heroin dependent is going to be different for those who are prescription opioids. I can tell you, if you think that folks who are in the bluff shooting heroin right now are going to have the same access to care as some middle-class suburban housewife or some rural kid in rural Georgia, you got another thought coming. They're not going to be viewed as the same way. They're certainly not going to be treated as the same way. I can assure you that those who are heroin dependent, shooting drugs in the bluff, are going to continue to be stigmatized, criminalized, marginalized, and did I say stigmatized? If I didn't, I wanted to say that as well. Look, I'm supposed to talk about some of the pathways. Well, Merrill said that David would talk about the ASAM levels. Unfortunately, I won't get that deep and I won't get that heavy. And let me tell you why. It's because, and I think it's on my next slide, before I can really talk about pathways, recovery pathways for people who are opioid users, opioid dependent, heroin users, heroin dependent, you gotta give me some demographics. I'm sorry. I've been doing this too long. You gotta tell me what gender they are. You gotta tell me what ethnicity they are. You gotta tell me the socioeconomic status. You gotta tell me how long they've been using and what they've been using. Because those things are going to help determine which pathways are probably most accessible and which ones are probably going to be more effective. But I just want to talk about some fundamental pathways that are fairly common and just briefly spend a little time talking about how they operate differently. Traditional treatment, and when I say traditional treatment, I mean abstinence-based programs. These are programs where you go into a program and you admit that having a drug problem and you make a commitment to not using any drugs as a way to start your recovery. Then you, historically when you leave there, you combine 12-step recovery like Alcoholics Anonymous or Narcotics Anonymous to sustain your recovery. It's a very old method. It's a very traditional method. It's worked for a great number of people, but it's failed an equal number of people as well. And historically, when people used to fail that particular treatment modality, we used to say it was because they were either non-compliant, they wouldn't do what we told them to do as their counselor, as their clinician, or they weren't trying hard enough. Today, we know that that's the furthest thing from the truth. And the reason why many people follow this treatment model is because one model doesn't work for everybody. So I just want to leave that there for a moment. Then I want to go to 12-step recovery, which is, the other thing I want to tell you about traditional treatment. Remember I told you I have to know your gender, your ethnicity, how long you've been using, what you've been using? This is why that's important when helping people identify different pathways. When you go into these traditional treatment models, abstinence-based programs, is what I'm talking about, and there's a zillion of them throughout Atlanta and throughout Georgia and throughout the USA. Historically, they tell you that you have to give up all your drugs. So if you go in there and you drink wine, and you smoke reefer, and you snort cocaine, and you shoot heroin, we're going to tell you that in order for you to truly be in recovery, you have to make a decision to give up all those things. Well, say if I'm a suburban housewife who had a minor knee surgery and left my surgery with a 30-day prescription for Percocet and 3 30-day refills. That's 4 months of Percocets that I can use every single day. And if I know Percocets the way I know Percocets, at the end of that 4 months, you might very well have an addiction to opioids. And then you end up in Southwest Atlanta trying to buy some street drugs because you can't get access to your prescription drugs. And then you end up in one of these traditional treatment programs. And they're going to tell you that you're going to have to give up that wine you have at dinner time because you have to give all drugs, including wine, in order to be successful in traditional treatment. Plus, you know, and I'm a traditional treatment person. I've worked in treatment many years. Plus, they go have you identifying as an addict, using that kind of language to identify yourself, alcoholic, when it clearly says in the DSM-5, and Merrill probably knows this a whole lot better than I do, that you have to have 12 months of consistent use to even meet one of their disorders for dependence, or at least meet the disorder for dependence. I'm not quite sure if that's the same for substance use. So traditional treatment is just not for everybody. Even though folks who've gone through traditional treatment, who've had a successful treatment experience, they'll tell you that the way to get recovery is to go to treatment. Then go to those AA meetings. That's the only way it works. Well, I'm here to tell you that that's not the only way it works. And that's coming from a closed-minded 12-step. I used to believe that if you didn't find your recovery in 12-step recovery, you didn't have real recovery. Let's segue to medication-assisted recovery. What I prefer to call medication-assisted recovery, I got that term from William White. I didn't coin that. As opposed to medication-assisted treatment, because for me, the end goal is recovery. Treatment is one of the many processes to help people find recovery. And we all talked about some of the medication that's being used now to treat people who are impacted by opioid use, opioid dependence. But I just want to highlight a couple, methadone and buprenorphine. And the reason why I want to highlight these is because methadone has been around forever. I remember when I was shooting heroin when I was a kid. I was 15, 16 years old. And my friends was in the MET program. And they would shoot heroin in the MET program at the same time. They tried to get me to get in the MET program. That scared me to death because I thought I was about to get too happy. I knew that heroin was killing me. I wasn't about to get another. And I want to tell you that there are many of us in my 12-step recovery program who frown upon medication-assisted recovery. They think that people who are methadone, Vivitrol, or any of the other medications that are used to help people recover from addiction, it's just substituting one drug for another. And I'm here to tell you that I was guilty of that for many, many years. It wasn't until I combined my lived experiences, remember that slide, with my formal education that I learned that again was the furthest thing from the truth. There are people who do quite well on medication-assisted treatment, like methadone. And I used to say, okay, well, do they have to be on it forever? Can they just get on it for a while and then get off of it and come to a 12-step recovery program and be okay with being drug-free from everything for the rest of their life? The answer to that question is maybe. Merrill talked about a step-down program. But another answer to that question is maybe not. I mean, I know folks who are on insulin, on high blood pressure medicine. We don't tell them to take their insulin for a couple months and then don't take it anymore, unless you're a doctor. You don't tell folks on high blood who have hypertension to take their medication for a while and not take it anymore. You know how long some people have to be on methadone? Until the day they die. And that's what it takes for them to be able to be in recovery. As they define recovery, this usually means having a job, reconnecting with their family, being reconnected with their communities, and so be it. Segue to syringe exchange. Now I'm telling you, this is a pathway, particularly for heroin injectors or others who inject heroin. It's not a popular pathway among some people, but that's unfortunate because syringe exchange has proven successful at reducing HIV and in some cases hepatitis C by 50% among injection drug users. Anything that reduces HIV by 50%, I'm in support of it. And guess what else it does? It does that very thing that Merrill mentioned earlier. For some people, provides them an opportunity to stay alive long enough so that they might be able to access some of the other options. Medication-assisted recovery, 12-step recovery, traditional treatment. And then one of my favorites, the faith-based approaches, and I know people will look at me and say, hold it, Dave. You ain't about to tell me you can take some opioid-dependent person and send them in church. Look, I got friends who swear they used to use drugs every single day to a point where they would meet a DSM-4 criteria for substance use dependent. Who walked into a faith community, got prayed for, and they ain't used it no more. I don't know if it works or not. I don't know if there's any science to support it, but if one of my service recipients, the folk that I'm working with, helping them overcome their addiction, say, I want to consider that option, let me see if that'll work for me, I'm going to be right there to support it. In the event that that doesn't work, I'm going to be right there to encourage them and link them with other support services. Or sometimes, some of these work hand in hand or go together. Like I told you, I combine my 12-step recovery with my faith and use that as a way to sustain me in my recovery. Look, let's just, you know what I want to ask the listeners and the presenters, the organizers to be honest about? It's this. The face of the opioid epidemic in this country has changed. It's gone from street users, most of whom were black and brown people, there's a whole bunch of non-black and brown heroin injectors, white people who inject heroin. Because it's for the most part, it's been perceived as an epidemic that was exclusive to urban settings, inner city communities, black people and brown people shooting heroin every day. This epidemic has changed. It's now impacting rural communities. I was in a county in Pennsylvania. I went to a town hall meeting on heroin. I get there, 300 people there. Now, I'm a former heroin user, so when I saw the ad, I got excited. I was in town working. I saw the ad, so I decided to get in my car and go. Decided to get in my car and go. All white people, 300. The mayor was there, the police chief, the fire chief, the school superintendent, everybody who's who in this entire county. They had 12 heroin overdoses among young white kids over a 3-year period. And they had a 300 people town hall meeting. I had a 12 people in my community overdose from heroin in 1 month. And we ain't had no town hall meeting in my community. Check this out. We need to be honest. The reason why we're having this webinar today is because of the face of this epidemic has changed. I told you that I'm not certain if this epidemic is inclusive of heroin users, brothers and sisters who are on the corner. I'm not for sure if that's what we're talking about when we're talking about spending more money, provide more care. I pray that they're included. I know there's folks on here who say, David, sure they're included. But I know what health disparity is. I know what it means when poor people don't access care at the same rate as middle-class people. I've been a part of it. I've seen it. I've been doing it too long. It's a part of my dissertation. I know that poor folk, black folk, ethnic minorities don't access care at the same rate as white people in this country. You can call me whatever you want to call me. Don't argue with me, though. All you got to do is read it for yourself. And you can see there's plenty of information. Part of Morehouse School of Medicine's mission includes addressing disparities, ethnic disparities when it comes to health care. Remember, let's not repeat history. This used to be a public health issue when white people were abusing codeine. What's the other one? You know the one that they give you when you have surgery? They used to the drips. Morphine! When white people were abusing morphine and codeine in the early 1900s. And then it went to a criminal justice issue when black people started using opiates. And now we're back to it being a public health issue. And again, in order for me to know what type of pathways, I need to know if you're male, female, if you're white or black, if you're poor or rich, what you use, how long you've been using, then I can better help you understand what your options are. I'm telling you, the lower you are in the socioeconomic status, the less likely you are to access quality care. And they're going to say, David, man, there's all kinds of programs in this town for poor people. I'm telling you, trust me, the quality of the care is not the same. There are two variables more than anything else that impacts a person's ability to achieve and sustain recovery. One is length of care. The longer I keep you in care, the higher the chances of having a successful treatment experience. The second is the quality of care. I can tell you what that means if you want to ask me a question. Look, this is a slide from hell. I'm going to try to tell you what this means, what this slide says in 30 seconds or less, because I know I'm running out of time. But I want to tell you this, too, that I have a link to this entire report. This was a presentation by Dr. Nora Volkow, who's one of my heroes. She's the director of NIDA, National Institute of Drug Abuse. This sister is super, super, super bad. Super smart. She's a brain expert, just like Merrill. She knows everything about the brain you can possibly know. She knows everything about addiction. This sister is bad. I just want to tell you what this part of her speech basically says. It says these things. It says that the number of heroin, opiate-dependent people and heroin-dependent people, she kind of keeps them separate, has increased slightly since 2005, between 2005 and 2012. It's increased a great number for people who are abusing prescription drugs. And for people who use heroin, the increase has been slight, but it's been about the same as it's been for as long as we've been gathering data on that. Are these factors? A couple of things you need to know is that heroin use presents a few more issues that we have to be concerned with. For example, if I'm a heroin user in the bluff injecting heroin, I'm putting myself at risk for HIV, hepatitis C, endocarditis, incarceration, murder, you name it. That's slightly different if I'm abusing Percocet and I live in Alpharetta. Now, I don't have all the same risk factors. So we got to be cognizant of that. So that means that we might have to provide care that's slightly different for a heroin user in the bluff than we do for somebody who's opioid dependent in Alpharetta. In closing, this is what I want to point out. This is a superstar system who knows everything about this epidemic and about the brain. In red, this is what she said. What was once almost exclusively an urban problem. I want to stop there because urban in this sentence is a code word. We didn't say urban when I was shooting dope. We called it the hood, the ghetto, inner city, black neighborhood. So that's what she's talking about. She said what was once almost exclusively a black people's problem. That's what she's saying. That's a code word. It's spreading to small towns and suburbs. And let me tell you, small towns and suburbs is another code word. She's talking about rural Georgia, where a whole bunch of black people live. And she's talking about suburban America that has historically been more white than black. So she's saying this was a problem that was once exclusive to black folks that's now impacting non-black folks. And I'm here to tell you that that is why we're having this webinar today. And so with that said, I just want to ask you to do this. Look here, man, these references, I hope you get a chance to access them because everything that I just told you in my presentation, including the part about this used to be an all-white epidemic, a white and a black epidemic, and how we went from a public health issue to a criminal justice issue, you can find in these references. But I want to conclude with this, that I pray that we don't allow this to go back to being a criminal justice issue, and I pray that we find a way to make sure that all who are impacted get access to care.
Thank you, David, and thank you, Dr. Norton, for extremely informative presentations. We have a small amount of time available for question and answer, so please feel free to submit your questions to the presenter, and again, and Amanda is still available to take any of your questions. Additionally, the webinar presentation can be found linked on the lower left portion of your screen. So we'll open for some questions. So our first question, what is the best setting to conduct opioid screening? And this question is open to either Dr. Norton or Dr. Whiters.
Well, it will depend. If you're looking at opioid screening, to be honest with you, I don't know a clinic that says I'm open to opioid screenings unless it's a MAT facility or an office practice, physician's office practice, where they provide buprenorphine, where people come in and actually evaluate, what kind of situation they're in. There's not, it's not, at least in my experience, it hasn't been a common practice for people to offer that kind of service. It would be great if people could, but it's, opioids it's the cornerstone of pain management, and also it has, the addicting issues with it, like Dave was talking about. And it doesn't really matter culturally which part of the world you come from, they still affect the brain the same way. So, and that's my input into it. So, David?
Yeah, there's plenty community-based centers. There are several SAMHSA-funded, state-funded community-based programs throughout the state of Georgia that could be an ideal place for people to go get screened for opioid use. Emergency rooms, primary care physicians, early qualified healthcare centers. All these places should be trained, if they're not already trained, to help people and assess people who suspect that they may be having problems.
Thank you. Despite the fact that the opioid epidemic and opioid and prescription drug abuse is well documented, in your opinion, why is it that many doctors or dentists still feel comfortable prescribing opioids?
Well, that's an easy answer. They work.
They're needed.
They work.
Don't send me out of the hospital with no surgery and tell me you ain't gonna give me something for my pain. That ain't gonna happen. It's needed and they work. So we just have to work with doctors and try to help them better understand what's the right amount and what's not the right amount. Nora may know this better than I do. I know my friend who had the knee surgery said that she got from her insurance company a survey that asked her, one of the questions was, did she feel that her doctor did an adequate job in controlling her pain? And if that doctor gets that same survey, he wants her to answer yes. What better way for her to answer yes is to make sure she's got adequate supply of pain medication.
I think the other issue, too, is that, and I've dealt and been interacting with a lot of prescribers, a lot of physicians over the last several months, and have listened to their concerns, and that, physicians are trying to identify a problem. Opioids are a mechanism for them to help manage identified medical conditions. It's not something they would regularly think about, this person's going to abuse this particular medication, until we started seeing people starting to die. And it really wasn't because so much of the physicians as it was the volume of prescribing. When I first came into pharmacy practice, my first hydrocodone prescription I saw was hydrocodone 2.5 milligrams, number 15, no refills, take 1-3 times a day. And when I'm in the pharmacies with some of my students recently, it was easy to see hydrocodone 10 milligrams, number 600, take 1-3 times a day. If you understand there's a huge volume availability, and people are obtaining these opioids not from their physicians, but they're obtaining these opioids, at least the prescription side of it, from their friends. And that's one of the things is I think a lot of the physicians are getting a bad rap saying they're overprescribing. I find a few physicians who do overprescribe, but I find most physicians are more than willing to do whatever recommended could do. And so the medical boards are coming back and said, well, maybe we need to refresh your opioid training, and that's basically what I think is going to happen. And we will see some difference in the prescribing practices, and we've seen a reduction in the use of prescription opioids. David can talk about heroin and the mixture with fentanyl, which is now so deadly. It's exploding. It's exploding because people, they will substitute one for another. And I don't know that the physicians are really responsible for a lot of that. So I just will tell you, you have to kind of look at both sides. Go ahead, David. Oh, guys, by the way, I've got class at 3:30. I have to leave you. Thank you all for joining us, and thanks for this. And but I've got to go to class, okay? Thank you.
Thank you very much. Thank you, Dr. Norton. Thank you, David. Thank you, Amanda, for an extremely informative and lively presentation. We understand that we were not able to get to all of your questions. However, we will share your questions through registration and through the live event with the presenters for them to provide their feedback, and then we will send the answers via email. We also encourage you to complete the full educational series. We have part 2, which will be taking place on October 11th, and it is a full part series, and we do encourage you to participate in all 5 parts of the series. On behalf of the National Center for Primary Care, we thank you for attending part 1 of our Opioid Use Management webinar series.